run the sucker right up the lateral cortex, and there's no step off. It doesn't jump out. There's no lateral neck there left at all. So protecting the abductor here, which is very important, and we don't want that to get too beat up. And I think we're out pretty far, so that's good. The piriformis fossa I'll take a little bit of. I want you to, just going to point out something that I've noticed. Let's show this a little bit better, and let me have that Steinman pin. Now you see this cortex comes, thank you. The cortex comes here. Now, with the piriformis fossa, the cortex comes back a little bit. I've taken a little bit away with my rongeur, but this cortex comes back a little bit, and that can also hold up your stem. This bone's not super important, so go ahead and remove that so it doesn't hold you up. And we'll be able to get that stem down a little bit better. Now, as far as the position compared to a flat taper stem anyway, we always make a big point to really push our hand lateral. When you look at the geometry of this stem, they tell us that we want this part of the stem parallel to the lateral cortex. Well, when I first started doing that, I think I paid a little bit too much attention to that. And what I did was, I watched, and then my stems were coming out in just a little bit too much varus. So I don't push as far or hard laterally as I do with, say, an anthology stem, but I am pushing a little lateral in order to keep it in the correct position. So it really shouldn't be much of a transition from an anthology or trilock or accolade or any kind of stem like that. And I start parallel to the posterior cortex, but of course, the femoral anatomy will dictate where the stem eventually goes.
And so just to clarify, that's your starter brooch, or the chili pepper, correct?
The chili pepper, yeah. And this is going to be this ought to be the -1. Okay. Now you'll see how the lesser troch to center measurement comes into play here. If my cup is in the right spot, then I can use the LTC as a bit of a rough guide to leg length so that we're not constantly guessing. In other words, doing a trial, checking the leg length, taking it out, etc.
So will you measure that now or wait until you put on trial necks and heads? Like how do you determine that?
I'm going to wait until I guess. Well, I'm going to guess in a couple of stems here when I think I'm at about the right spot, and then I'll measure it. And if I'm close, then I'll go ahead and take a trial range of motion. So I'm at the 0 here.
How far down?
And you can see I'm holding the mallet at the I'm
how
holding
far
the
down
mallet at the top of the mallet. You see, I'm holding it up here just so I don't want to generate too much force.
How far down will you sink these trials?
Well, I'm going to go until I think I'm at the right length. In other words, the LTC that I am measuring. I'm probably going to check it here at the 1 stem. And again, remember, my neck cut was a rough cut. It's just a guess. I'm going to fine tune it after I get my stem to the right spot.
When you take that brooch or that rasp out, can you show that to us? Just the differences between the first initial rasps and in this rasp.
Of course, right. At the size 1, you actually have a choice to go with a cutting rasp or this impacting rasp. Now her bone is slightly osteopenic, and she seems to be cutting well, so I told them that we don't need a cutting brooch. I'm just going with an impacting brooch. And from the 2 on up are all impacting brooches.
And as opposed to other designs, this is circumferentially impacting, correct?
Correct. As it seems like it's down on the cortex. This is 1 size under from where I templated, which again is very, very common. So I'm going to go ahead and check my LTC and see if I'm close. If it's close to that 45, 46, I'm going to go ahead and take a trial. And we've modified our ruler. So we're right on the money there. I think we're exactly where we started. So about 46, 47. So we're going to take it through a trial range of motion now. You guys can all come out.
Will you calcar plane or leave that little extra calcar on there?
I will make the x-ray look very pretty. Just take out the third body wear and the face full of blood. Okay, go ahead. Now I'll put my drapes back to where they were before so we can check our leg length accurately.
So
I take this through.
We kind of blew through which modular neck you chose, and that's obviously one of the benefits of the SMF. So you want to tell us which modular neck you chose?
Yeah, thank you for reminding me. Well, we always start off with the high offset neck, and I tend to use the high offset neck much more commonly than the anteverted neck. I kind of think of the anteverted neck as just kind of a bonus when you need it. But most of the time, I would say my numbers are about 70-30. So the first test I'm going to, and I'll take it through a range of motion, and if I'm not happy with my combined version or my stability, I'll go ahead and trial the anteverted neck. If I'm very happy with this, I won't even bother going to the anteverted neck. So now, I'm going to take you through how I test. Good, thank you. No, we'll leave this down. I'm going to take it. First thing I do is I check the tension on the anterior capsule. So I'll take my hand over the patella, and I'll go ahead and pull back. I'll rotate it back, and this is checking the tension on the anterior capsule. Okay, so we'll pull back on this, and if it just touches your finger, which is laying on the ischium, I think that's pretty good tension. So I like the tension on the anterior capsule. It tells me that I have enough offset. And then the next test, and grab the sucker. The next test is going to be my coplanar test, or my combined version. And Eric, hold this for a second, thanks.
So just walk us through that. How do you determine the combined version?
Yeah. Very good. Yeah, here you go. I'm going to hold that. And Eric, just put your finger here so they can see just a little bit better. So what I'm looking at is the equator on the femoral head, and you guys can see that. Now that I will rotate. In other words, I'll put this in neutral extension, the hip, and I will rotate this until the head is coplanar with the cup. So it seems like that looks about coplanar there. And I think that we're at about 40 degrees, 40 to 45. I tend to shoot for 25 to 45. This would be the safe zone. Men tend to be a little bit lower than women. And I think that's a good or a rough guide to use to help keep you free of impingement if we stay in that 25 to 45 range. So I'm pretty happy with that.
Can the camera just pan out a little bit so we can see where the leg position is while you check that?
Exactly, and that's what I'm looking at. The knee is at 90 degrees of flexion, and I'm checking the angle of the tibia to the floor, assuming that we're in neutral rotation with the patient's body. So I'm pretty happy with that. Now I'm going to go ahead and stand a little further down here, and I'm going to check extension, adduction and abduction, and external rotation. Make sure we're not coming out the front, and also make sure we're not having any posterior superior impingement, which we don't seem to be having at all. And then I'll take it into flexion, and there's no impingement here. And I would say she comes up to about 60 degrees or so of internal rotation. So what I'm going to do is actually trial I'm going to go ahead and trial the anteverted neck.
Do you test or place any importance?
I think a long time ago I might.
Do you test or place any importance in the so-called resting position?
The resting position? I don't test that. Hold on one second.
So again, you said you probably 70% of the time go to the high offset. Do you ever use the standard offset neck, or did you template for the high offset? How did you determine which initial neck to trial with?
I did template with the high offset, and I typically do not use a standard neck. And when I look at the x-ray, I actually take more of a qualitative assessment of how much offset there is. And she has some decent offset on the X-ray, so we're sticking with the high offset. Okay, so I think that we've increased our combined anaversion somewhat, and we should have 10 degrees, and I think that's pretty close. And we're going to make sure we don't have any impingement, and we don't come out the front. And again, we're free of impingement. I'm going to bring it up, and we should have a little bit more internal rotation, so I think I'm much more comfortable with that. Now we're going to go ahead and check the leg length. We have the Steinman pin. And when I bring that straight up and down, I think we're in the same exact spot. So I'm happy with the leg length. I'm happy with my stability now. We're going to go with an anteverted neck. And now you can go ahead and open up the one.
So while they're doing that, can you maybe have your scrub tech show us the different modular necks?
Oh, great. Can you? She doesn't have an earpiece in. Tara, would you mind showing the different neck options, the different modular necks? Go ahead and hold that in. So we have the standard and the high offset, and then we have an anteverted neck for the right and the left. When you combine all that, including, you can also flip that and have a retroverted neck. And you combine that, you have something like 42 distinct head centers for the SMF stem. Let me see the calcar planar, please. In this moment.
And so again, just for the audience here, those retroverted and anteverted necks can be flipped, not on the rasp, but on the actual implant, as you'll see in a minute. They can be flipped upside down, and so you can have right anteverted and left retroverted. Obviously, that will change your offset and leg length, and there's certainly tables. It's approximately +6 degrees of change in leg length when you do that. And hopefully, we'll get that demonstrated here in a minute.
Okay. Now we'll take a look at the, yes, you can open the anteverted neck. We'll take a look at the stem here. You can see the stick tight up here and the rough blasted surface, and just the satin finish here. I leave this white piece of plastic in just to protect the female taper from the blood. But we'll go ahead and impact that in.
How close do you feel that the actual implant aligns with where you ended with your rasping?
I am almost always line to line when I go back and I recheck my LTC. Occasionally in the young males with a real thick cortex, despite really blasting away with the broach, we'll sometimes sink down 1 or 2 millimeters. But other than that, I would say over 90% of the time we're line to line. And now when we look at the anteverted neck, important is an arrow on here, and if you're using the right anteverted neck, the arrow is obviously going to go up, and you can see we have a 10-degree angle on this for the version. So I'm going to go ahead and place this. Let me see the yellow head, please.
Just before you finally
recheck my LTC.
Just before you finally impact that, can you take it out and flip it around for us to show us how you can use those modular necks?
Yeah, we may be.
That's fine.
There we go. Yeah, and so doing it this way would give us a higher angle, and this would be retroverted, 10 degrees retroverted.
Excellent. And there are trials for this, so you could trial again at this stage if you wanted to, correct?
Yeah, can you bring up some of those plastic trials? You can see that. The plastic neck trials, those things that we never use. And again, there are plastic trials if you want to
But they are available
before you commit. Yes. Yep. And let me have the...
They're
back.
color-coded, they're
Go
red
ahead
and green.
let's watch.
They match the boxes.
Hang on one second. I just want to recheck my LTC. Let me have the Smith & Nephew ruler, please. Here it is. It's good. And we're at the same LTC, so I'm very happy with that. So I don't think at this point that it's necessary to go ahead and just push down a little bit here. I don't think it's necessary to retrial. We're at the same length. Go ahead and watch that. Good.
How old did you say this patient was?
She's 63.
63.
And she's fairly active. Great.
And which head are you going to go with?
She's pretty active. We're going to go ahead with and use the Oxinium head.
Do you have
As
any
my rep likes to call it black magic.
any age cutoffs, activity cutoffs, comorbidities for using Oxinium versus cobalt chrome?
Well, nothing hard and fast, but I'll consider age and activity level generally. So a 63-year-old that's very active, who plays one sport, maybe tennis or golf, I'll usually consider the Oxinium head, especially with the new data that sounds like everyone's going to live to be 120. Now, there are studies that they did test this neck. You don't need to impact them separately. You can go ahead and wait for the head to be on to impact both the neck and the head. Great.
How long of a neck length will you use? Do you have any concerns about using long neck lengths with the SMF?
I certainly try not to go beyond +8, but occasionally if I need a little bit more offset, I'll use a shorter stem and go with a little bit of a longer head. Okay, yep. Tonsil, please. Oh, 1 second. A little loose body in here.
Have you ever found that even with the SMF you've had to take that neutral liner out and go to a 10 degree?
I haven't. I would sooner take the cup out and reposition it. I try not to use a hooded liner. Okay. Well, that's it. We're going to go ahead and repair the capsule here. I'll show you how I do that. Can I have the drill, please?
While you're beginning to close, I'm going to open it up to the audience, see if anyone here has any questions for you.
Okay. And the needle.
Yeah. Great. Yes, sir.
Hi, Fred Wilson from Phoenix. I was at several at the ICLs at the Academy, and they talked about the use of the modular necks and head combinations, and there was a lot of concern being raised about the torque issues and stuff, and some of that's been addressed this morning. And so kind of the prevailing opinion seemed to be at the ICLs that it's a good tool to have in the toolbox, but it should be avoided except in cases where you actually needed the modularity, that you should go with a solid trunnion. And I wondered what the prevailing feeling is about what the proper indications are for using the modular neck.
So the question was, I don't know if you could have heard that, Brad, but the question was... Go ahead.
Yeah, if you want to repeat it for the audience, you can do that. I heard him pretty clearly, though. I think that's been my philosophy as far as how I approach using a modular neck. Again, just the fact that it's 70-30 should tell you that I don't plan on using it, and I think it's there if I need it. So it's better to have it and not need it than need it and not have it.
So do you use SMF for all of your patients? I think the question probably boils down to patient selection. So do you use SMF routinely or only for certain indications?
I use SMF routinely, and I don't discriminate as far as any ages. That's a common question that comes up. I've used them in anywhere from a 25-year-old to a 93-year-old, I think is my oldest. I have not revised any stems. I have one infection, and I think I have maybe one, possibly two calcar cracks, which a simple cable was necessary, but there were no sequelae from that. I haven't had any subsidence, no revisions for loosening. And I have about 250 implanted now.
And Mark, and so we're going to have a debate after lunch with just exactly the topic which was brought up. We're going to have a pro-con on using modular stems for all primary stems, so that should lead to a lively discussion afterwards.
So did you go through drill holes in your greater trach? I didn't see that. It looks like you're going all soft tissue to soft tissue.
Yes, well, this is right. The maximus tendon right here I just repaired. This is the quadratus that I'm bringing back up the vastus, and here I made two drill holes for those two corners of the capsule to come up.
So again, while you're closing, can you talk a little bit about your postoperative rehab? How soon will you attempt to ambulate these patients? What sort of restrictions do you put on them, et cetera?
Oh, great question. Well, this patient will get up today. When she gets up to the floor, once the spinal wears off, she will at least stand in her room with the therapist, and then tomorrow she'll have 2 sessions of therapy. While in the hospital, I do use hip precautions. I think it's just easier for the staff. Some guys here use it, some guys don't. So I find it easier not to confuse the therapists and the nurses, so we make them a little paranoid about their dislocation precautions. And then I typically relax most of the precautions after just a couple of weeks.
And what sort of postoperative analgesia do you use? Do you use a multimodal approach?
Yes, we use a multimodal approach. You know, she got a that's good. She got Celebrex and oxycodone prior to the surgery, and she does not get patient-controlled anesthesia. And I'm just feeling the capsule back here, and I'm flush with the trochanter. And my assistant is putting a little bit of external rotation on the capsule, and I'll go ahead and hand tie this. Emily, just put your hand there just for a second. Good. We'll just go ahead and hand tie this.
So what oral agents then do you use post-op if no PCA?
Right, typically it's oxycodone every 3 to 4 hours, and they'll get Celebrex for about 5 or 6 weeks. I think it's a good agent for as an anti-inflammatory and also to help decrease the risk of heterotopic ossification. They all go on Xarelto, factor 10A specific inhibitor for DVT prophylaxis. They'll be on that for 35 days. My patients seem to like it. I've been using it for over 6 months. I have not had any hematomas, no reoperations for it, no aspirations, and there's no monitoring of the INR. It's once a day. It's not adjusted for body weight, and you don't have to worry about what you're eating, and they don't draw blood.
Have you had any issues with the wound, any wound oozing, that so-called Lovenox ooze, or anything with Xarelto?
Yeah, no, I actually haven't. We've been checking it very carefully because once we decided to try the Xarelto, I've been checking all the wounds very, very carefully, and I haven't had any issues. And I'm a Coumadin user beforehand, and we didn't have many issues with the wounds, and I don't see any difference at all. I'll take the cocktail first.
Do you use
I use a pain cocktail.
All right. What's in that?
So this is just Nerapin. Pickups, please. This is Nerapin and Toradol. Nerapin is the enantiomer of Marcaine, and a little less cardiotoxic. And I'll do the sub-Q, and I'll get the maximus tendon here, and I'll go through the capsule as well. The Toradol works very well. It doesn't have to be metabolized by the liver first, so it acts directly. And I also use Toradol in my knee scopes as well.
Any issues with renal function in injecting the Toradol locally?
I always check. Her creatinine is 0.8, and her BUN I think was 17. So she was okay. But if it's borderline, then I will not use the Toradol. I'll still use get the abductor here. I'll still use the Narrowpin though. Getting the posterior capsule, staying away from the nerve.
Back to the Xarelto, have you had any issues with cost? Patients complaining about high deductible or the increased cost with Xarelto compared to Coumadin?
We haven't really had much of an issue. I'm going to take the on-Q now. This is, and I'll answer that in a second. This is the on-Q catheter, and I have Marcaine in that. I use a 5-day Marcaine, but I only keep it in until post-op day number 2. But as far as the cost, the company has been very, very good as far as helping out the patients who have any kind of issue with getting the medicine. They have programs, so you should always talk to your rep. And I have it on formulary at all my rehab places as well. I'll take that Tycron now.
So tell us again what you just put in.
That was the on-Q catheter. It's a Marcaine-eluting pump. It's just a catheter, and I put that into the hip joint through the superior part of the capsule.
And you said you'd leave that in for
repairing the
2 days?
Yeah, that comes out post-op day number 2. And then they're discharged on post-op day number 2. My patients, here regionally, most patients go to rehab. It's just the way it is in New York. I would say 75 to 80% of patients in this area will go to a rehab facility. We actually get them out on post-op day number 2. So she's a bit of an exception. She'll stay till Monday because they don't discharge on Sunday. But typically on a Monday, everybody leaves on a Wednesday. So our hospital stay is 2 days.
And I take it you do not use
I use the Tycrons here on the fascia here. I use 3. It's a marking stitch. This is how Dr. Ranawat taught me. And it's actually very helpful in a revision situation so you can keep your fasciotomy consistent.
Do you use any drains with your total hips? Obviously, probably not with the on-Q, but have you in the past?
Correct, I don't. I think my first year or 2 I did, and then we got away from using those.
Okay, any other questions from the audience? We're just about perfect on time. We'll let you finish closing here. Any last thoughts? Anything else you'd like to convey?
No, I want to thank you guys for having me, and it was a pleasure.
Thank you. That was an excellent demonstration of both the R3 and the SMF. Hope your x-rays turn out as well as the operation went. All right, thank
great.
you all.
I'll see if we can beam those over to you.